blood gushing out, whatever is happening. And you're first seen usually by a triage nurse, someone who's going to assign the severity.
Yep.
I guess triage means 3. I guess it's super severe, pretty bad, and we'll see him when we can.
And where did that term come from?
Please tell me.
That came from Napoleon's physician, I believe.
I think you're right.
Triage. So they would teach people how to differentiate who is okay, who is either dead or too far gone to warrant help, and who needs to be addressed immediately.
Hello, welcome to the Dr. Gil Show. This is where we talk about medical matters that matter to you. My guest today is Dr. Orlando Heredia, MD, MPH. Welcome to the show, Orlando.
Thank you.
Would you tell me your name in perfect Spanish, please?
Orlando Heredia.
Orlando Heredia. Oh, that sounds so sexy. That's beautiful. Orlando is a friend of mine. We've known each other for over 17 years now.
Yes.
He is a doctor and a medical doctor, and he practices emergency medicine here in central Missouri. Emergency medicine, Orlando. That's a big, big topic. You had to do a lot of training for that, didn't you?
Yes. Emergency medicine is fun, and I really didn't want to study medicine. I wanted to be a lab geek, kind of like maybe you did for a while and still do. And I thought being a researcher would be also the way for me to get to the United States and emigrate, because I've always wanted to live here.
From where?
From Mexico.
From Mexico.
Even though I was a border kid, that's why I don't have an accent, because I grew up watching The Cosby Show.
Gotcha.
And even though you're not supposed to talk about The Cosby Show anymore. But anyway.
Right. So where? Laredo? Where?
Tijuana.
Tijuana. Yeah.
I'm born from TJ, so San Diego. I went to kindergarten in San Diego. I watched all the San Diego TV.
That's why your English is perfect.
Went to the beach in San Diego. Went to La Jolla Shores.
Black's Beach.
Never went to Black's Beach.
Never to Black. That's the first place I went.
Black's Beach is a nudist beach for those.
It's optional. Clothing
optional beach in San Diego, yes.
That's right.
And so I thought a way to get into the United States to do research would be, instead of pursuing that kind of line of study in Mexico, which is not very developed, I would say, be just do medicine.
Right.
So here I am.
So did you see the show ER? Remember the theme? Remember ER? And you had Benton, and you had George Clooney, and
Eric LaSalle.
Eric LaSalle. He was the general surgeon, the tall, handsome black guy.
I think more importantly, Eric LaSalle was in Coming to America.
Yeah, so did you
He was the Soul Glow guy, if you remember that commercial.
Yeah.
He was awesome. Anyway, I did watch ER when I was in.
Was it Julie Margulies?
Yes,
Julianne?
yes.
That was her name. Mm-hmm. She was really cute.
So I watched that show, and I thought it was entertaining, and I did not internalize the fact that it made an effect on me. When I decided to go and study medicine, I thought, if I'm going to do something, I'll probably just do general surgery.
Right.
And then when I started having electives in general surgery and having to wake up at 4 a.m,
right, and
stand up for hours operating, it was not for me.
Right.
And then I saw that I actually really wanted to do EM. And I had a mentor when I was doing some electives at Harvard Med School. And he said, "Oh, you definitely need to do EM." And so I went and did emergency medicine, and I would not do anything else.
Fantastic. Now, it's called emergency medicine. It's done in an emergency department. But for some reason, it's called an emergency room.
Yes.
And that just stuck.
Old-timey.
It's old-timey. Like the show we were just talking about. It wasn't ED. It was erectile dysfunction. It was ER in an ED.
I guess I hadn't thought about that.
Yeah, ED. It's got a whole different name now.
It used to be a room that did not have any permanent medical staff. It was a room with nurses. And some countries still practice this. Depending on the nature of the complaint, a intern or some other very low training person would be called in. So if it was something that sounded medical, the internist or internal medicine intern. If it was something that sounded surgical, they called the surgery intern.
Okay.
And it was a room with stretchers and curtains, and that's where people would be examined. Now, this is 1950s, 60s, probably.
Okay.
Before, modern medicine developed and emergency care grew, and now it is its own specialty. And as you know, it's a massive thing that is
a big deal.
That we cannot provide enough services.
Yeah, we're going to get into that. So, roughly, when did emergency medicine become a recognized specialty? Do you know? I didn't look it up. I should have looked it up. Somewhere in the 60s or the 70s?
Late 60s.
Late 60s became a bona fide specialty.
It was a specialty, but it was housed in academia under general surgery. So it was a division, usually, of general surgery in most academic institutions. And it took until the 90s and 2000s, probably, when emergency medicine became its own academic department in most institutions.
Well, that's interesting, and that kind of makes sense. So you did some electives at Harvard. You went to residency at WashU in St. Louis, which is a very prestigious academic institution. And where did you also got a master's in public health. When did you get that?
Yeah, my MPH, I thought it was a good thing to do between finishing medical school and starting residency, because as you know, getting into residency is competitive,
right,
and challenging. And as a foreign medical graduate, it's a lot harder to get into a good program. So I had 11 months between residency starting and me finishing a year of research in Mexico City. So I actually said, well, what could we do for 11 months? And a good friend of mine who's a cardiothoracic surgeon now said, let's go get an MPH.
Brilliant.
And we've always been pretty geeky and nerdy and love more
knowledge. It. So no gaps in the resume. None of these lethal gaps.
We immediately
people look for those.
Finished our research year, flew to Boston, and stayed there for 11 months and got our MPH. And throughout that time, we interviewed for our residency spots. That's how I ended up in the Midwest. I'd never been to the Midwest before until I started interviewing for residency. Anyway.
It's a very, very, very special place in the country. We've got the best of all worlds, I think. And I won't go in. A great cost of living and great colleagues. So let's talk about emergency medicine. Apparently there's 131 million visits a year to emergency departments in the United States. And if you do the math, apparently 42% of all people are going to visit an ER per year. 42%, Orlando.
Well, a lot of those are repeat visits.
Okay, we can slice it and dice it, but a lot of us use the emergency departments. And apparently 38 million injuries are seen in emergency departments. And apparently of all the people that walk in your door, up to 14% are admitted to the hospital. So these are sick people.
Yes. And actually, where we work, which is the hospital you work at, it's 20%
or
more.
So sick people.
So 1 out of every 5 that rolls in is going to stay in the hospital. But it varies. It varies tremendously.
Day to day and whatnot. Now, this is something interesting. I was watching some show on TV a few years ago about doomsday scenarios. You have these super rich people buying nuclear silos and turning them into apartments and refuges and whatnot. Apparently, the most valuable person that they want on retainer is a doctor of emergency medicine. So when the end of the world comes, you have the primo, most valuable skill set of anyone on the planet.
It used to be that most physician astronauts were surgeons, but now most physician astronauts, I believe, are emergency docs.
Yeah, so emergency, then family medicine, and me as a reproductive endocrinologist, I'm down on the bottom. Nobody wants to freeze embryos during nuclear holocaust. Although I would play up, I could probably fill in as a surgeon of some sort. Now, emergency departments are famous for their long waits, waiting for hours and hours and hours. But apparently, 50% of people that walk in an emergency room are seen within 15 minutes. Now, I don't know if that's the triage nurse. Now, let's explain what that is. You come into the emergency room, blood gushing out, whatever is happening, and you're first seen usually by a triage nurse, someone who's going to assign the severity.
Yep.
I guess triage means 3. I guess it's super severe, pretty bad, and we'll see him when we can.
And where did that term come from?
Please tell me.
That came from Napoleon's physician, I believe.
I think you're right.
Triage. So they would teach people how to differentiate who is okay, who is either dead or too far gone to warrant help, and who needs to be addressed immediately.
That was the 3.
Yep.
Beyond repair.
Mm-hmm. And now
last rites.
What we use is a 5-grade scale, where 1 being immediate life or limb threatening, and 5 being, I need a refill of my prescription.
Right. What we call bullshit suburban trauma. When, I was in an ER when my boy, he had been bitten by a spider, and his ear was this huge glowing red cherry thing, hot ear, and you could see the 2 little dots. It was a spider bite. Even I could tell it was a spider bite. I remember being in the waiting room there, and we started chatting with some people next to us, and this guy had a little dot on his arm, and they were sitting there to be seen by an emergency doctor for a little tiny skin dot. I wanted to reach over his triangle and say, what are you wasting these people's time for?
Because that is an erroneous concept that a lot of people have.
What is?
In emergency medicine and emergency departments are just different providers of healthcare. The concept of an emergency is subjective. It's not objective. You can't tell somebody what an emergency is. If they feel that they're having an emergency, it's an emergency. And a lot of people cannot access care anywhere else.
Sure.
Because if you want to go to an urgent care that's privately run, you need to have a copay.
You need to have money.
Or you need to have money. So we are obligated by law to see everybody. You are familiar with EMTALA, the Emergency Management and Labor Treatment Act.
Right, labor. The part I know is if a
yes.
woman's in labor, you got to admit her.
Yes.
Speaks English, insurance, citizen,
it doesn't matter.
Don't matter.
If someone, but that applies for everything. So if someone presents to us, they have to be seen no matter what. And that came about because there used to be patient dumping in the 70s where what we would call a wallet biopsy. People would show
up. Biopsy.
People would show up to the hospital. Do you have insurance? Do you have money? No. And then they would be redirected from private hospitals to public hospitals. Or
right, to the county, the famous county hospitals.
So, which is what our hospital used to be or still is, county hospital.
Technically, we're county, yeah.
Mm-hmm. So that law came about so that wouldn't happen. So everybody gets fairly seen. And that means that if a person, independent of where they come from, what their problem is, shows up in an emergency department in the United States, they have to be screened for a medical emergency. That is the obligation from the law. They have to have a MSE, a medical screening exam. So they have to be seen by a registered provider who can determine if they have anything that needs to be addressed emergently.
And that can be a nurse.
Depending on the institution, it can be a nurse. Okay. But that's not necessarily what happens. The obligation is for everyone to get a medical screening exam. And then if they have something bad, it has to be addressed. And if they don't, they can be told, hey, this is not an emergency, go away. But instead of that happening, what happens is everybody just gets seen.
And that's where you hear about these waits. So that person with the little dot on their skin might be the 7-hour wait.
That person is going to be the 7 hour.
Is going to be the 7 hour.
And that person will get seen. And we will talk to them and make sure they feel heard and take care of their problem within the limits of our ability, and then discharge them or do whatever needs to be done. But because they're not that sick, they are put in line.
In line, the lower priority.
Yep. So anytime, if you are a triage 5, anytime a 1, a 2, and a 3 shows up, they get seen first. And so you keep waiting.
Gotcha.
But eventually, everyone gets seen. Sometimes in cities, it's more than 12 hours.
Wow.
But they get seen.
Gotcha. I've seen billboards by the side of the road. The last one I saw was in Albuquerque. Mm-hmm. I was driving, and it had the ER had the wait time in real time. It had the numbers up there. Yep. Gee, only 5 minutes now, or 50 minutes, or whatnot.
It has been suggested that we should do that here in Colombia.
What are your thoughts on that?
Let's not do that right now. Because then it's just gaming the numbers. It's somebody shows up, checks in, and then someone else says, "Okay, hi. You're okay. You've been seen. Go to the waiting room." And it's just fudging the numbers, but they end up still spending many, many hours until they get done.
Gotcha.
They haven't really been taken care of. They've just been eyeballed.
They've been eyeballed and triaged.
Mm-hmm.
Gotcha.
Now,
gotcha.
that isn't ideal. That is an ideal. That is something that we want, because we don't want people waiting. Some of those people that are waiting are sick, and the longer they wait, the worse outcomes they have. We don't want them waiting. We want everybody to be seen quickly. Mm-hmm. Except it's challenging. It's very difficult. But I would be happy if everyone had a 10-minute, what we call a door-to-doctor time. 10-minute door-to-doctor time would be amazing. Absolutely amazing. Everybody walks in, gets eyes on them. We can immediately tell who needs something quickly and who doesn't.
Yeah, last time I was in an emergency room, waiting room, I had a family member with presumed COVID. There was a guy sitting there with a cut on his eyelid. Oh, it was terrible. And I remember him just sitting there 2-3 hours, just very patiently just sitting there. Obviously, you probably called an plastics or an ophthalmologic surgeon, and and they were coming, and you were going to get into what you sew up. Obviously, you sew up a lot of cuts. That's part of your skill set.
Not so much anymore.
Really? Why not?
Because that's what the younger people like to do. So I'll let them do that.
I see.
You know, I'm kind of more the senior person now, so I try to pick up the more challenging stuff.
Interesting.
And it's not It's really challenging stuff. It's just complicated.
Interesting. So, you apparently are a family man, Orlando. You've got kids and whatnot. Do your kids think you have a glamorous life? Or do they never see you? Or are you just like they just see you maybe on weekends or something?
No, I think we have an excellent work-life balance. I think they have a very good understanding of what life is, what challenges exist, and that if you want to achieve something, you just have to work hard. I think they get it. My oldest, I have brought her to work a couple of times, and it was interesting to see. She said, "Yep, medicine's not for me." Okay.
Yeah, my boy's the same way. When he's editing my surgery videos, he's doing it with a half an eye because he doesn't want to see me opening up people's
Whereas
bodies.
My second one was like, "Yes, I want to do that." Okay. No pressure. You do whatever you want. But I do love it. I would not do anything else. But at the same time, I'm careful of not doing too much, because some people that work too much end up missing out on the other things.
Right. They'll live without having lived.
Mm-hmm. And regret.
Yes.
You don't want to have regret. I do see people on the deathbed. Seeing them with regret is absolutely terrible and it's heartbreaking. Whereas when I see people who are having a nice or decent or positive death,
yes,
it's a lovely thing to see, because
that's true.
I mean, not necessarily lovely like you want them to die, but it's, things can be.
Oh, there's a good death.
There's definitely a good death.
There is a good death,
and we all die. Every day around is a good day, and if we can make it even better, that's awesome.
That's awesome, Orlando. So you've been able to strike a good work-life balance, and your kids think you're pretty cool.
I don't know.
Have a good job.
We're all right.
Good role model. I do want to say that Orlando also works out at the same gym I'm at, and I like to lift weights, but boy, you like to spin. I see Orlando spinning on the bike. Oh my goodness,
we like to do a little bit of everything.
You're incredibly fit, and it's good you do that. You find time to do that.
Yes. So, and speaking of that, one of the big things that would benefit society is more of a culture of activity, because unfortunately we spend too much time sitting down, sitting around, not moving, and that leads to the burden of what I have to deal with at work.
Yeah, the chronic disease.
It's
kind of interesting here in this. We happen to live in Columbia, Missouri. It's a college town, Midwest, about 120,000 people or so, without necessarily the students. It seems that every strip mall, every day, some new exercise things comes up. Like they've got not just the hot yoga and the regular yoga, but they've got the jazzercise. the 50 different gyms, the purple one and the yellow one. But a boot camp just opened up where you pay somebody to be a drill sergeant to kick your ass for an hour.
Whatever works. But these are things for people who have time and have resources.
Right.
And the vast majority of people are struggling to get enough hours at work.
Right.
Support their family.
Paycheck to paycheck.
Paycheck to paycheck. And these things are not just something that's the best for everyone. But what everyone can do is move. Everyone can take a walk. Everyone can walk their dog. Everyone can take the steps.
For the most part. Right.
Instead of taking the elevator. Yes. I mean, of course, the ones who are able to.
Yeah, who are able.
But many who are not able, it's because they didn't do it before. So I think it's extremely important to emphasize that physical activity, getting up and moving around every day, is something that we were designed to do. Genetically, evolutionarily. We were designed to be moving, not necessarily running, not necessarily lifting weights, but just moving. And when we move, we do better. And the farther away you get from your bed on a daily basis is it's correlated to how long you're going to live.
Oh, I love it. Not necessarily grip strength or something, but how far you get from your bed.
If you can get from your bed to the park on the other side of town, you're going to live a long time. If you can only get from your bed to the bathroom, your lifespan is a lot shorter. If you can only get up from your bed to the bedside commode and back to bed, you're not going to live very long. So I find that fascinating how that correlates, because it's true. We are designed to be moving.
I love it. A doctor I follow on social media, Peter Attia, he recently came out with a book talking about the importance of exercise. It's like 4 or 5-fold more important than your diet, for example. Yes. It dwarfs other interventions.
And the concept of needing to go to the gym, needing to exercise per se, I think is not that it's erroneous, but it needs to be tweaked. It's just a question of thinking of moving.
Like I've heard that people in solitary confinement in a 6x4 hole, if you have the right mindset, you just being on the ground, you can do. There are books about prison workouts you can do just on a floor and be pretty jacked.
Just sitting up without something to lean back on. At work, I don't use a chair. I use a stool because you're engaging your core when you're sitting. We're not designed to do this. We're designed to be doing this, or even better, sitting on the floor, because that's what humanity grew up doing,
I'll be darned. This conversation, I thought it would be all emergency room blood, guts, and gore, has turned into a health talk. This is wonderful.
This is causation of chronic disease.
Avoiding chronic disease.
What do we do at work? Sometimes people have accidents, but what kills people? Accidents don't kill people. Chronic disease kill people.
As far as the numbers go. Right.
Correct. The vast majority of illness and sadness comes from chronic disease. And that is diet, lack of movement, but also, your social environment, your family environment, your thoughts.
Sure. And then you throw in some bad luck and some genetics, and you've got the whole picture there. Very interesting.
You throw in some global warming, and next thing you know,
oh man,
you can't even think.
The heat. The people have been dying of the heat. It's been yesterday was 102 and 85% humidity. It was just deadly out there.
And we're lucky we have air conditioning, but
many
people don't.
We are really blessed.
So what we see at a non-academic, non-trauma center is chronic disease more than anything. If we were a academic trauma center, then we do see, of course, the car accidents and the fancy stuff that you see in the TV shows.
I like the high-speed missiles. That's the name for a bullet.
Yes, high-speed missiles.
It's amazing.
And all of the shockwaves that they cause inside of the body.
If you don't realize, it's not the hole, it's
the ballistics
the energy. Oh, my God. That goes laterally.
And no, we see chronic disease. We see the ravages of heart disease and vascular disease, diabetes, hypertension. And what does it do?
Right.
Heart attacks, strokes, and disability. And that's what we see all the time.
in your type. So let's unpack this. Let's start talking about, let's get more into the weeds here. Let's talk about I looked up the major categories of things you would typically see in an emergency department. And to my surprise, number one, at least in one list, in one hospital, was headaches.
I'd say headache is top 10 for sure.
It's top 10. Yeah. So headache. And in this list, it was number one. So got somebody comes in, walks in the door. Doc, my head's killing me. What does Orlando think? What can you do to help this person?
The way in the emergency department everything works is it's a ranked kind of military situation where the providers are in charge and they tell everybody kind of how things are running because it's too busy and there's not enough people. So we have nurses, we have techs, which is someone who is not a nurse but knows some stuff.
Some experience.
It could be an EMT. It could be a paramedic also. And a variety of other people who are crucial, like the radiology techs, the registrars, the people who do the registration.
Even they could have an eye for this.
Yes. And the people who are around, the custodial staff who's around cleaning, every single person is key to make the department flow. The moment something breaks down, everything goes to hell. We even have a phlebotomist in our department. We have a social worker.
Somebody to draw blood. Phlebotomist draws blood, and a social worker.
And a case coordinator. No, we have, it is very, very complicated, and we need a lot of people. And when one person is missing, things do not work well. So when someone comes in with a headache, the registrar sees them, gets their information, puts them in the system, they get their triage by a nurse, they get evaluated, they get their vital signs. Is this headache serious or life-threatening, or can they wait? Do I have a protocol so I can give them some medicine while they wait to be seen? Maybe they don't have to wait. Maybe they come in at the perfect hour, which is 4 a.m. when nobody waits, and they get straight back and get seen. And then, with our experience and training, we determine if their headache is anything bad or good, and then treat them.
Gotcha. So the registrar can tell you, gee, there's an arrow going through this person's head. I think they should be seen right now, right in
but the idea,
or
of course,
an axe hanging out of their skull.
Again, door to doctor time to 10 to 15 minutes is the ideal, and it can happen. Some people just walk in. Oh, there's a bed back there. Just come on straight through. We'll register you and triage you in the room.
Do strokes sometimes manifest as a headache? I know stroke is typically, I've seen the posters. There's the droop. There's the speech problem. Maybe they can't walk the same. Does headache ever?
So two of the big life-threatening things that we're trained to jump on very aggressively are heart attacks and strokes. They are the same thing in different locations.
Oh, explain that, please.
We all need oxygen. Every part of our body needs oxygen to function. And the blood is just a mechanism for transporting oxygen everywhere, right?
Okay.
Our red blood cells carry oxygen. So from the lungs to the heart, to your fingernail, or to your eye, or to whatever needs oxygen. So if one of the arteries, one of the pipes that carries blood, gets blocked, whatever that pipe is feeding stops getting oxygen and dies. So if a coronary artery that is feeding the heart gets blocked off, that's a heart attack because part of the heart dies. If a artery in the brain gets blocked off, that part of the brain stops getting blood, and that part of the brain dies. So it could be the part of the brain that controls speech. So then the person has one of those strokes where they can't speak. Or it is a blockage of the artery that feeds one of the eyes, and then that eye becomes blind. So when you see the classic presentation of stroke, it's not always classic. It's not always going to be face that's
like the poster.
Paralyzed. Or yes, it could be many, many things. And the most challenging strokes to identify are the ones that occur in the back part of the brain, because they can just make you unbalanced.
And so the cerebellum we're talking about?
Yes. So just nonspecific loss of balance can be a stroke, and it's terribly difficult to identify because it could just be, you're dizzy, you have vertigo, you're dehydrated, you're overheated.
So a lot of things it's called a differential diagnosis. What are the things that it could be?
Our job is to listen to a person's complaint, and create a list in our mind of a differential diagnosis. So if you have a headache, why do you have a headache? In my mind, I have to say, do you have a migraine? Do you have a tension headache? Do you have a stroke? Do you have, oh my God, there could be so many things.
So many things.
And then go through the list mentally. This is what we do. Go through the list mentally. If there's a test that needs to be ordered to confirm or disprove one of these, we do that if necessary, and then provide treatment. So it's two separate things. One is treat the problem, but the other one is identify the problem. And you can't identify the problem well unless you think about all the possibilities. So our job is a thinking job. It's a cognitive job. It's not like on TV where people are running around doing things, putting tubes in people and sewing things up. The vast majority of what we do is think and make decisions.
It's called the assessment.
The assessment.
Drives me crazy when I get records and they've got all the blood pressure and the fine, and then there's no thought. There's no what I call intellectual horsepower on the assessment.
Or it's not documented. It was done, but it wasn't documented.
It's not there.
Yep.
You've got enough to make the insurance company happy and tick the boxes, but you don't
have to do that.
Right. That's what you're paying for.
So earlier your question was, do our headaches, can they be strokes? Not the classic stroke that we think of. A classic stroke, which is a clot or a blockage of an artery, usually is painless.
Okay.
But if you have a brain bleed, which some people call a stroke, so
is that called a wet stroke? Is that a wet stroke?
Oh, I haven't heard that term before. A wet stroke.
Oh, you know, there's dry strokes and wet strokes. Even the gynecologist knows this. The dry stroke is where it's blocked, and you don't have perfusion. And the wet strokes when you bleed.
I like that. That's cool.
So, okay, so you've got a hemorrhage, brain hemorrhage. Oh, boy, I'm feeling so smart here. So you've got a wet stroke, so you have to figure that out, too.
Because if you have a clot in the brain from a stroke, you're supposed to go to the hospital quickly, because if you get there soon enough, we can give you a clot-busting medication that is a very strong blood thinner, which, if you are having a brain bleed, getting that would be the worst thing. Catastrophic, right? So it is imperative that we make sure always that there is no bleeding associated with the stroke.
So today, while we're on stroke, let's just talk about this in depth. I know Boone Hospital is right now a stroke center, and part of the team that takes care of these are interventional radiologists. These guys don't just look at chest X-rays all day. They actually can put little tubes and thread them into all the different parts of your body, including the arteries that supply the brain.
And the veins.
So they can go in there and take out plugs and clots.
So being a stroke center, an institution to have stroke certification is a big deal, because they are equipped to take care of any kind of strokes quickly, and that requires a lot of resources.
It's a whole team.
Yes. So our hospital, Boone Hospital, does have that. We have 24/7 coverage by neurologists, and we do have neurointerventional radiologists, and we have neurosurgeons. So whatever stroke situation comes in, us in the emergency department will take care of it, and then we have the support of the specialists to continue their care afterwards in the hospital.
So to be a stroke center, you need brain surgeons, interventional radiologists, neurologists, and all the support staff.
And that was what I was going to say, not just them, but all the staff that's trained to take care of all the little details.
Special nurses, that's a big deal.
Because rehab, or many people who have a stroke need rehab, and we have a rehab facility too. It's a big deal. And that's a big deal. That's just a stroke center, but there's also what we call a STEMI center, or a certified center to take care of heart attacks.
All right, since I have just learned they're just different, same thing in different parts of the body. What do you need? What does STEMI stand for?
So most people call it a heart attack, but we call it a myocardial infarction, right?
All right, there's an MI. I see the MI.
There's an MI. So an MI, myocardium being heart muscle, and infarction is an area that does not get any blood and dies. So an MI is a myocardial infarction. It's a heart attack. I saw someone with a heart attack yesterday.
I bet you do.
And she did not look well, but she came to us, and we are a STEMI center, or a heart attack center. So that means, similar to a stroke center, we have all the support staff and the specialist to take care of that. So if
and
someone
interventional cardiologists,
Yes.
they also put little tubes
so
into
the
these.
specialist cardiologist will put a tube into the arteries and thread it up into the heart, squirt some dye, identify where the blockage is, and open it up. And that is supposed to be done 30 minutes by 30 minutes after a person arrives.
30
or 90
minutes.
90
90 minutes.
90 minutes.
They're in a cath lab.
Yeah. And so they're in the cath lab, and what it's called the door to balloon time, because what opens up the blockage is a tiny little balloon. So the door to balloon time has to be 90 minutes from when someone walks in the door to when they've been diagnosed with a heart attack, sedated, catheterized, and opened up.
That is amazing.
It is actually
and
one of the
you can
wonders of
routinely
modern
do that.
medicine, and we do that routinely.
All the
Absolutely,
time.
it's one of the benefits of living in the United States, that we have
Yes.
this very advanced healthcare that is not accessible to most places in the world.
Oh, man.
It's lovely. So I lived in New Zealand 3 years ago. We took a year off, and I was an emergency doctor there.
That's where you were.
And we did not have those resources because it's very expensive, and you need a lot of specialists to do that. And I was working in a very small hospital. So everything that anyone who would present with something like that needed to be either transferred by an ambulance or by helicopter to a referral center.
So what's the big city in the North Island? Is it Auckland
Yes.
or Christchurch?
Yes.
Or where?
Christchurch in the South Island.
It's the South.
Yeah.
So you'd have to get them to Auckland. That doesn't sound like 90 minutes to me.
Well, it's not that big. The landmass of New Zealand is the size of Colorado, except it's kind of stretched out lengthwise.
And even prettier.
It made me appreciate the vast differences in our healthcare systems, because there's a lot of good stuff here and a lot of bad stuff. So we should probably talk about how hard it is to do what we do, because that's why people have to wait 8 hours sometimes.
Because you're getting that heart attack in the cath lab within 90 minutes.
Yes, but that actually moves quicker than grandma who's been weak for a month and is just not functioning at home and has a list of 25 medications and is brought in by the family. That is not something that we can figure out in 30 minutes. That takes many, many hours, many tests, many conversations, and that eats up a tremendous amount of our time and energy.
Yeah, and I can tell you as a medical student, back when in the emergency department, when it was the dreaded nursing home dump, and as people called it.
Well, it was an emergency room back then, right? When you were in medical school.
When we were busy using chisels and
candles.
And candles, right? And bear skins. And yeah, there's
It's complicated.
It's complicated. So you have this usually elderly, frail individual from a nursing home, and they're decompensating. It's 2 a.m. They're on 20 different medications.
And so, but these people deserve our respect our honor and our care. But unfortunately, take a lot of resources, a lot of time and energy, and that's why we end up not having enough resources, not having enough personnel to see everyone expeditiously. And it's difficult to communicate that to someone with a open eyelid that's bleeding in the waiting room, because that open eyelid can wait. Because it can.
Because it can.
Because it can.
And this phrase. So, boy, talk about intellectual horsepower to try to figure out a person who's deteriorating all over, multi-organ system failure. That's something you never want to have.
So our population is getting bigger. Our population is getting older. So in the United States, there are more people, and everybody's getting older, which means more needs from the healthcare system. And we are having difficulty getting enough people to do so, especially after COVID. COVID was the source of a massive surge in physician and healthcare and nurse burnout.
And retirements.
And so a lot of people retired early. We don't have more medical schools churning out more doctors. So we have a shortage. We have a national shortage of everything.
It's not just family doctor. It's not just emergency medicine.
And that makes it a lot harder. So that's why you are seeing the normalization of, let's call them advanced practice providers, of APPs, which are nurses and physician assistants. There's no way around this unless we open our doors to foreign immigrant physicians. The only way we can deliver care to our patients in the United States now is with the assistance of advanced practice clinicians, APPs or APCs. So when you see a nurse practitioner or a physician assistant, don't consider that abnormal anymore. They are key team players in delivering care now, and we spend a lot of time and effort making sure they are well trained and that they are well supported, so they can take care of everybody.
We need all hands on deck. And when we do score a wonderful doctor or nurse from around the world, the Philippines or India or something, they are now short. Now you've drained the brains from that country. So we skim off.
Correct.
We skim off a lot of the best people from other parts of the world. And if you want to look at justice and overall doing good, then we're not helping those countries either.
Well, we're also warming the planet more than most other places, so that's a different thing.
It's a whole nother thing. And once again, as we're in the middle of a drought and 102 degrees today, I know it's a big topic.
So what else would you like to know about
I've got
emergency
a whole
medicine?
list here. So we've done headache, stroke, chest pain. How about abdominal pain? There's a lot of things in the abdomen. There's the stomach, there's the intestines, there's the kidneys that you feel, there's the pancreas, there's the appendix.
The uterus.
The uterus can feel like an abdominal organ sometimes. Ovarian cysts
The
and whatnot.
belly is a black box that does not tell you specifically what's happening.
Yeah, because the pain can be almost any. When it's all inflamed, when one thing goes bad, the whole thing's inflamed.
Thing goes bad.
Where do you go?
And abdominal pain can represent a vast array of things, and some of the things are not serious or life-threatening, but painful. And other things are serious and require surgery.
Right.
My kid had appendicitis a few months ago. And that was a thing, to go to the ER and wait for a long time till finally got back, and then waited in a room for an hour till someone walked in. We were patients, and we were trying to be patients. And
tough.
And that was a case of abdominal pain, which we see regularly also. So abdominal pain is complicated because whatever is hurting, you can't tell what it is. Is it my small intestine that's hurting? Is it my kidney that's hurting? The pain is not very specific. And some of the information that we're told can help us differentiate, but a lot of times we end up having to do tests because of that.
Now, what is the magic testing modality that has revolutionized abdominal care?
The CAT scan.
The CAT scan, and boy, they have sped it up. Used to have to be in there a long time. Now, how long does a CAT scan take now? 2-3 minutes or something? Really quick. So you put somebody in the scanner.
So what is a CAT scan?
What is a CAT scan, Orlando?
Oh, I'm going to answer. Okay.
I'll make you do it.
It's computer-aided tomography. So it is an X-ray, but instead of just being a two-dimensional picture, which like a chest X-ray, you'll see just a picture of the chest.
Yeah, they just put a film up there and blast through it.
A tomography is a 360-degree a turntable where X-rays are performed sequentially as the detector or the emitter of X-rays spins.
That donut's going around you.
It's the X-rays are going around taking X-rays, so it creates a 360-degree picture, and then it moves the body up or down. So that 360-degree picture then has the third dimension added,
the slices.
The depth. So then it turns into a three-dimensional picture of the inside of the body. So the advent of computer-aided tomography many years ago was a game changer. Back in the day, back when you were a young doctor.
Tell me how old I am.
We didn't have that available, so people just had to they were sick enough that they needed to stay in the hospital, and if they got even worse, then a surgeon had to open their belly and look around for what could be the cause. Whereas now, we can get a CAT scan and identify what the problem is.
Very accurately.
And that's, yes.
And sometimes you put a little contrast dye in there, You took care of my mother-in-law not too long ago, and she had a bleed inside of her body, and you put some contrast in her vein, and there it came out, and it showed up in somewhere, and you could accurately make a diagnosis.
But more than half of those scans are, quote, normal. And why are you having pain? Is it
right?
There's this whole big thing now that we see a lot of, which is functional abdominal pain. It's a nice big term that doesn't mean anything specific. People who have abdominal pain, but we can't identify a cause, but we think it's just because things don't function right. They don't work right, but we can't tell exactly why. So when you hear the infamous term IBS, irritable bowel syndrome, what is wrong? Nobody knows.
Nobody knows.
It's probably functional, quote unquote. It just doesn't work right. So then we can start to look into this whole world of the nervous system of the gut, right? The intestine has its own nervous system. The intestine is bathed in nerves that control it and move it. And all those nerves are connected to the brain. So our brain is controlling our stomach and our intestine. Our brain is controlling our liver and our gallbladder, but we don't control it voluntarily. It's happening automatically. So some of these painful disorders are malfunctions of this neurologic system, but we don't get it yet. We don't understand it well yet.
And it doesn't show up on a CAT scan.
And it does not show up on a CAT scan.
It's not a lesion, meaning a boo-boo somewhere.
A boo-boo, yeah, a thing. That's what I tell people.
Yeah.
I can't see a thing that's causing the pain. That doesn't mean the pain is not there.
Right.
But an important thing for people to know also is that not all pain is hurting you. Just because it hurts, it doesn't necessarily hurt you. It can hurt you emotionally, which is important.
Right.
But it's probably the point of the pain to hurt you emotionally so you pay attention.
Right.
But it's not necessarily hurting you organically.
A noxious stimulus, you could call it.
Mm-hmm. And so a lot of people have pain that is not necessarily hurting them physically.
So, help our listeners, Orlando. When is belly pain, abdomen pain bad enough that they say, you know what, maybe I shouldn't take 2 Tylenol and call my doctor in the morning. Maybe I should get up, get in the car, go to the emergency room, or even worse, is it so bad, should I call an ambulance?
If you pass out, bad.
Bad. Passing out
is bad.
So if you pass out, let's say you don't live alone, somebody witnesses pass out, that's bad. Get to the emergency
department. If you're
so
so weak that you can't get up and walk, bad.
Bad.
If you have a high fever, bad.
What's a high fever? 101, 102?
I would just say most people don't have a thermometer.
Okay.
If you have sweats and shaking chills and you feel terrible, that's bad.
That's bad.
Yes.
I like this. I can understand this. Okay.
Right? And then everything else, take a Tylenol, see if you can go on a walk, give it a little time, and then see. And that applies to everything.
Okay.
There are certain things bad. If you are having chest pain, go to the hospital. If you think you're having a stroke, go to the hospital.
Or you think a family member's having a stroke.
Absolutely.
Go to the hospital.
Those are emergencies. But if it's some belly pain and it's hurting, but you can move around and function, you can wait a little while and see how it goes.
See how it resolves.
Mm-hmm.
Because gas pockets can hurt like hell, but they move. But terrible.
Terrible. I thought I had a heart attack once, but I was really just having some squeezing in my chest because I was drinking too much coffee.
In medical school, I went to the emergency room for chest pain.
Mm-hmm.
It was costochondritis. The day before, I had jacked up my car to change the tire.
Mm-hmm.
And I had done this.
And you hurt your chest.
And it hurt like hell. And they diagnosed me with costochondritis.
Mm-hmm.
At least I was seen quickly because it was chest pain.
Yes, that's is that a secret we're supposed to tell? I don't know.
It was something that I feel like a secret code word. How do you get seen quickly?
Yeah, at least you'll definitely get seen quickly by triage and by the nurse. But if your initial tests look okay, you will wait.
You will wait.
You will wait.
You don't have those dreaded ST changes.
Yes.
Those electrocardiogram changes.
Or,
I think that's part of the STEM.
What is the most reliable test or the most reliable tool we have is our eyes. We can just tell who's sick.
Right.
And people don't see that when they come in and say, why did that one go straight to the back and get a room and I'm still in the waiting room? Because we can just tell by looking at them that something is bad.
Once you got some experience in there.
And that is something I really, really value when thinking about hiring someone, is if they have experience and they have the eye to determine who's bad. I remember when I was a medical student, actually, and I did a rotation at UCSD Medical Center in San Diego. And one of the grandfathers of emergency medicine was there. His name's Peter Rosen. And Peter was in the ER sitting there, and he would watch the patients as they would walk through, and he would read their complaint on the computer, and he would diagnose them. Effectively and appropriately just by looking at their complaint and seeing their walk. And I thought it was absolute magic. How can you just see this person walk by, look at their vital signs and look at their complaint and already know what's wrong? Until I started doing that, years ago. It's like, oh, you just had so much experience. And that's very, very valuable. We just can usually tell when someone's very sick or something's going on.
That's fantastic.
It's pretty cool.
It's a theme that comes up over and over in these interviews, Orlando, how important experience is. In the training, you have to have the right training, you have to have the right attitude, and you combine that with experience. You can tell a lot. And I don't know if artificial intelligence or Watson's ever going to be there. I know they say it's getting pretty close, but so far I want an experienced doctor like you rather than Watson.
For now,
now,
things will change.
Yeah,
everything changes, and a lot of experienced people, if they don't keep learning or keeping open to new things, are not the best anymore, and they're not as good because they're stuck in their ways, right? And that's not necessarily good either. We have to keep learning, we have to keep teaching, and we have to keep staying open. And so AI is unavoidable. And
it may help us through this crunch, the provider crunch.
It is a new companion to humanity. What is it going to do to us in the future? I try not to think about it.
Yeah.
I'm just living the day today and enjoying it because I don't know what's going to happen.
Yeah, I don't
Have you asked ChatGPT things recently?
No. Well, the big shakeup in my world is we can test embryos to make sure they have normal chromosomes, which you got to have. If you're going to have a baby, it needs to have normal chromosomes for the most part. There's rare balanced issues, but let's just use plain English. They're starting to advertise testing now where you can look at an embryo and say this one has a higher risk of schizophrenia or heart disease, or this one doesn't. So now there's gradations. And this is just the beginning of the things they're going to start looking at.
So it's not modifying them.
No, not
there
modifying
is no modification
but
yet.
Scoring them.
But there's screening and scoring, like this is the good one.
This is the better, or the better one, and what criteria we use. That's scaring the bejesus out of me right now, and I will not be alive to see the end of this one. But I hear you. That's changing everything. So I was really not surprised to see that one of the top 10 reasons people go to the emergency department is for toothaches. And here in the United States, for some reason, dental care is different from medical care.
Yes. You interviewed a dentist recently.
I did interview Dr. Ryan, Pat Ryan, my dentist.
Oh, was he your dentist?
Yeah, there are many like him, but this one is my own.
Yeah, so dental care, people with Medicare and Medicaid do not get dental coverage.
Right.
And people who get private health insurance, it's not the same as dental insurance.
Yeah, it's a separate carve-out thing that you pay for.
I don't know how that happened and why it's separate and different.
It's just ridiculous because I've said this before. In the old days, the number one reason for suicide was tooth pain. It was so bad.
Back in the day. Well, that's why people come in. They don't have.
So it's excruciating. You can't think about a thing. So they come to your emergency department with tooth pain. What can an ER doctor do for tooth pain?
Antibiotics and pain medicine. That's it.
Do you ever inject some lidocaine in there?
Yeah, we'll do a block.
You can do a block.
Yeah.
You stop the.
But it's temporary.
Right.
It's just like the block you get. It's like the block you get at the dentist. It lasts a few hours, but then it goes away. So we can do that for people if they ask for it. Absolutely.
And try to hold them over until they can see a dentist. If they can.
If they can. And if it's a weekend. So there's a lot of pain and suffering regarding bad teeth out there, unfortunately.
Yeah, and unfortunately, it's a socioeconomic indicator. If you see somebody with bad teeth, they're generally not upper class.
And it smokers.
And smokers.
Smokers, I rarely see people with bad dental pain that are not smokers.
Interesting. So it's something modifiable.
It's kind of curious, right? Because we used to see smokers all the time, and now smoking has turned into a bad thing.
Right.
And if you travel abroad to Asia or to Europe, everybody smokes.
Right.
It's kind of weird to see that.
Right, right.
So it's good, but there's still a lot of people that smoke.
I am so old, Orlando.
Mm-hmm. How old are you?
I'm 62. We used to go in the middle of the night when we were medical students. We used to go to the nurses' station where they were smoking.
Oh, yeah.
They would smoke in the nurse, like in the hospital, not out in the back. In the nurses' stations where everybody smoked. That's where they did their charts, had a smoke, had a cup of coffee. Smoking right there.
My wife tells me a story that when she was younger and her grandfather was in the ICU, the ICU doctor, the pulmonary specialist, would squash his cigarette, put out a cigarette on the ventilator tubing as he was going rounding on the patients, which I thought was like, well, that's kind of dangerous because there's a lot of oxygen.
There, yeah.
But they didn't care. Old timey.
How people don't believe it. It happened. It was true. If there was a cute nurse on Tower 9, you go up and have a smoke. I think it was Tower 11.
What else do we tell people about emergencies?
Broken bones.
Mm-hmm.
I broke my arm as a kid. I remember going in there. Just recently I saw a martial arts fight about a month or so ago. It was two women, and she landed on a straight arm, and she snapped. Oh, she was howling. She went to the emergency department somewhere, I betcha.
Yeah, we fortunately have great support from orthopedic surgery.
So do you set bones at all yourself, or do you call the pod?
That's a great term, setting the bone. You know, that was a very old-timey thing.
Oh, I'm aging myself again. Okay.
Let me set your bone, which means essentially just straightening it, right?
Yeah, kind of put it back together, cast it up,
we do immobilize fractures, and sometimes we will straighten them or reduce them a bit. Okay. If it's going to take a good amount of work, then we do call the orthopedic surgeon to come in, but they don't always have to. Yeah,
we have a large, great orthopedic program in at our hospital. Mm-hmm. So always somebody on call for that.
Yes, and there's a lot of advances in that too. People like 100 years ago would get a broken bone, maybe have surgery, but they would never be right again.
Yeah.
Be a little crooked, maybe not as efficient, and we're very lucky now to have specialists who can get us almost back to normal. My kid broke his femur, which is a huge deal.
That's a big bone.
And we thought this is going to be with him for the rest of his life. He's just not going to be right. And he was not walking straight for a while, and now he's back to 100%. So it's amazing.
And it missed the growth plates, I hope.
It was right next to it.
But it didn't hit the growth plate.
And so one of the things that we see a lot of is hip fractures. Someone who's older who falls, lands on their side, and breaks their upper femur right there by the pelvis.
Right, so you got the pelvis, and you've got the ball at the end, and you've got this trochanter, and there's this neck. There's this weak spot right there between the ball and the trochanter. You tell me if I'm right. And you hit yourself on the side, and boy, that can snap.
And it snaps, and it used to be a death sentence.
Yeah, the mortality was like 50% or something.
Because nobody would be able to fix it, so immobilization was the treatment. The person had to lay in bed for 4 to 6 weeks.
And if you're 70 years old, bad lungs,
what
bad
happens
kidneys,
when you can't get out, right?
As
the
Orlando
distance
said.
from bed, yes. So they would get pneumonias and blood clots and this and that, and then they would die. Now they come into the hospital, they have surgery, and they walk the next day.
Whoa,
so
the next day.
It's amazing the advances that we have access to, and that's why people are able to lead a longer, healthier life.
That one must be, that person tries to walk by. That's an easy diagnosis, right? They're not walking.
Well, they're not walking.
They're not walking. They have a history of a fall, and they're older and weaker.
But one thing we definitely need to talk about quickly
Please.
is the opioid epidemic.
Oh, we were getting to psych and drug addiction.
So we know that here in the United States, over the past decade, we've had a tremendous amount of people who have become dependent on opiates.
Yep.
And that is a illness that affects everyone.
Every family, every walk of life.
Yes. And it in part, I think we were responsible because we would prescribe too many pain medications to people.
Yeah, remember the reps. I remember the OxyContin reps said there's all these different vital signs. There's your height, your weight, your blood pressure, and they added on another vital sign. Pain. And no one was supposed to be in pain.
And even 6 years ago, every single day I would see more than one patient who ran out of their pain medicine, were withdrawing, were stressed out. I need some pain medicine. And my doctor, who usually gives me my pain medicine, is out or won't refill it right now.
Right.
And that is
torture.
actually
Withdrawal is torture.
It's terrible, and that has improved substantially.
In what way?
Well, I think what happened is the governing bodies of medicine and the federal government have made it a lot more difficult to just prescribe and not have consequences. So we have to be much more judicious and careful to who we prescribe pain medication to.
So do you think there are fewer people becoming dependent? Because there's less supply?
No, there is less of a problem of people coming into us requesting refills on their pain medicine.
Okay. Because they never got there in the first place.
Because they are not getting their pain medicine from a doctor, which is what would happen in the past.
Okay.
So at least that component of the problem, getting addicted to pain pills because doctors would prescribe them pain pills, I think that has improved.
Okay.
Unfortunately, it's being replaced by fentanyl.
Right, and street drugs of unknown potency.
And that's why we have a tremendous amount of overdoses and opiate addiction, because then you become even more dependent when you use those kind of medications.
Now, do those folks who are overdosed, do they usually come via ambulance? Do they ever walk in the emergency room?
Yeah, or they get dropped off.
Yeah, what?
They come in many shapes and forms. Like they could just come in because they're withdrawing and they don't want to keep using, or because they don't have any money and they can't buy any, or they get brought in by family members who really want them to get help, or a car drives up, a door opens, and they dump somebody who's not breathing, and then they leave.
Right.
So the fact that naloxone, the antidote, is now available to a layperson without a prescription, I believe, is a big deal.
Now, if you have a pet, don't the ambulance, the EMTs, don't they have a protocol if someone's passed out? Don't they give them naloxone and sugar and glucose?
Yes.
Because that cures a lot of the reasons for people who are unconscious,
for people who are
right?
unresponsive, yes.
Do you do something like that too?
Yeah, we check everything, really. Of course, we check blood sugar initially and look at their eyes to see if they could be overdosed.
So is it a fixed pupil? Is it
it's small,
small
pupil? Although not all opiates do that, but yes, we'll try that. But we also have it get an EKG and make sure their heart's pumping correctly. Maybe that's why they're passed out. Maybe they've got a brain bleed. Yeah. No, then we have to do our thing, which is very broad. But
how do you give naloxone?
You can give it
a nasal spray
in the nose. Okay. You can give it as a shot in the muscle, or you can give it through the IV. It's awesome.
So you can give it any different way.
You can give it many different ways, and it's very, very safe. So we still are dealing with an opiate epidemic. We have to be very careful when we prescribe people pain medicine, and we are trying really hard to get people the help they need. There is a statewide, at least here in Missouri, a statewide program sponsored by the Missouri Hospital Association that's called EPIC, and they have a group of counselors, therapists, ex-addicts who will go to the emergency department or to the clinic where someone is in distress asking for help, and just talk to them, help them, drive them to an appointment with a counselor, get them into rehab. It's awesome.
We have that resource.
Yes.
You can get someone in the help they need in rehab at your hospital.
At any hospital and any clinic. It's just a phone number. You call that phone number. I wish I had it with me. And it was strictly for opiates when the program started.
Okay.
But it has now expanded to alcohol, methamphetamine,
Any substance dependence.
Any substance dependence, yes. And the crisis is also, like I mentioned earlier, like an emergency. It's a subjective concept, right? If someone thinks that they're in crisis, and we need to help them.
Well, I'm so glad we have that resource. I know they're not cheap, and I know funding is difficult, and there's a lot of prejudice towards people with substance dependence. I'm glad there's some kind of help there. Leads to another really tough type of patient is going to come in your department, Orlando. That's somebody with a psychiatric illness. Somebody has a break, they're off their meds, they have maybe an undiagnosed schizophrenia or something. That must be very difficult to manage.
And that is the mental health crisis that we would deal with more back in the day. A schizophrenic who is acutely paranoid, delirious, agitated, someone having hallucinations, requiring sedation.
Possibly violent.
The vast burden of mental illness now is not that.
Was it suicide?
No, it's just it's depression and it's anxiety. And you know that the younger generations are having a lot more trouble with this.
It's huge. Anxiety and depression.
And that social media.
Half of my patients.
Social media makes it worse. Our phones, our screens make these problems more endemic and more challenging. And that is something that we see every day. And if we didn't have the support of a social worker in our department all the time, and if we didn't have the support of the mental health resources here in town, I don't know what we would do, because people would not be able to get help.
Because I know psychiatry was grossly underpaid, undercompensated for decades. And if you look at the hierarchy of, prestige and salaries, I think psychiatry was below pediatrics. Now, we need both. But I think psychiatry is finally seeing some kind of renaissance, because I believe there's been such a shortage of psychiatrists. They can now command
higher pay,
appropriate salaries.
Because they're needed.
They are needed. And I don't know if this is true for our hospital, but I believe there's one psychiatrist with telemedicine covering 4 or 5 hospitals. I could be wrong, but there's such a shortage of psychiatrists that we are having to rely on these physician extenders, these social workers.
Yes. And just like with everything else in healthcare, we can't just rely on doctors. So there are other professionals who do a great job also, counselors, therapists, and people who deal with acute psychiatric emergencies and psychological emergencies.
That's a big chunk of what you do. It must be very difficult.
We have to always be patient, be compassionate with that, because someone with a bleeding eye is next door, and we need to go sew that up, and that takes a while.
Right.
But this other person also needs attention. So it's a multitasking challenge, what we do there every day. And I do also need to appreciate everyone in this on our staff, every nurse, every tech, every secretary, everybody who works with us, because they're all dedicated to helping everyone. And we want to help prevent them from burning out and being able to feel supported and appreciated.
Yeah. So when you have a cut, there's a question I have. When you have a cut, I remember as a medical student, a person had a cut on their lip. And there was this magic line called the vermilion border, whether you're in the pink or the white. And I don't know, it was a millimeter, but it was into the vermilion border, so they called plastics.
Yes.
And the ER doc wasn't going to do it. It was plastic. So how do you decide whether you or one of your colleagues is going to stitch up a cut? Like I mentioned, I keep remembering this cut eyelid on this poor person. When do you decide whether you're just going to sew it up and send them home, or you're going to have to call in some help?
Our most common circumstance where we need to ask for help is in a hand with a tendon injury. The tendons are the cables that pull on the muscles,
very special surgery,
and they move the bones. So we see cuts to the hand all the time, and if we identify that, so that's something that's very important. We need to make sure we can check the tendon and that it has not been cut.
How deep is the cut?
Even if it's shallow, it can still nick a tendon.
Because they're so close here.
Yep. And if we identify a tendon injury, that needs to be seen by a hand surgeon. It doesn't need to be seen immediately. Many times we just wash it out, close it, immobilize it, and send them to the hand surgeon in a few days. That's okay.
That's okay.
Yeah. But it still needs to be identified. Otherwise, that weakened cut tendon won't heal well and it can snap in the future.
Gotcha.
So that is one of the most common things that we request help on is plastic and face things, because we at our institution, it's not a trauma center. We don't see such terrible injuries. So most things, even an eyelid or a mouth, we can take care of.
You can take care of it.
Yeah.
Gotcha.
The body is amazing. The body heals very well. We're lucky.
Yeah. So another thing you see a lot of is upper respiratory infections, which leads me to COVID. What was life like a couple of years ago in the height of the COVID epidemic, Orlando?
Well, it was strange, right? At the beginning, during the worst part of the epidemic, the emergency departments were empty because nobody wanted to come out. So only the sick people came in, the ones that ended up in the ICU, but everybody else stayed away.
Stayed home.
So emergency medicine had a challenging time because we were not getting reimbursed because we were not seeing a lot of patients. So a lot of people were their hours were cut or they were let go. That was the first part of COVID.
How counterintuitive.
And then once people started going out and taking off their masks, we were understaffed and it was a mess.
Oh my goodness.
So we are having a resurgence now. We are seeing COVID every day.
Yeah, there's some sick people out there, EG5 or whatever that is.
But they're not as sick as they used to be. So we are seeing COVID every day, but the people are not terribly, terribly life-threatening ill like it was in the past. I think it's going to turn into like a flu.
Yeah, it's going to be a chronic thing. We'll all have some type of baseline immunity.
And there's going to be a flu season and maybe a COVID season, or maybe COVID will always be around. And we'll get a vaccine hopefully every year for it, like we do for influenza. And we'll just ride it out.
And you'll catch it in daycare with chicken pox and everything else. And
I mean, there are kids in school right now with COVID.
Sure.
That have a cold and a cough, and they're spreading COVID around. The problem is, the sick and the elderly and the immune suppressed. But otherwise, I think it's just something we're going to live with now. Hopefully, unless there's a mutation that gets messy.
Yes. That's the thing of science fiction writing and.
But the vaccine was a game changer.
It sure was.
Yeah.
Sure was. People say, well, people caught it as much. Yeah, but they didn't. You're much less likely to die or need to go to the hospital. Mm-hmm. So whether you have the virus is different from being sick. Yeah, that is a fraught subject, fraught with controversy, and I'm just going to leave that alone. So you also deal with back pain. People throw out their back. Oh, that's a tough one. All right.
So top 5 reasons to go to the emergency department: chest pain, abdominal pain, weakness, back pain.
So how do you address back pain? Obviously, you get a history. With G-Doc, I was bending over and I picked this thing up and I felt something go.
Mm-hmm. We are a species that stands on 2 feet. We are, again, not designed to sit around. We're designed to move, and we sit around a lot. So probably 60 to 70% of humans have experienced back pain, many on a regular basis. Many people have chronic back pain. I have chronic back pain.
Sure, me too.
There you go. Why?
Because we evolved on all fours for millions of years.
It's amazing how we don't understand things as well. And I believe there are studies that have compared MRIs on people with back pain and MRIs on a similar group with no back pain, and the spines and the herniated discs and the nerve roots look the same.
Or equivalent.
Why do some people have horrible pain with the same anatomic changes as someone else who does not? It's, I think, a complex process between our interpretation of what our body is telling us, our lifestyle, our approach to discomfort, our habits of moving, sitting, walking, our mechanics. If you're hunched over, even if you walk a lot, it's not going to be the same as if you stand up straight. Right. And there's a tremendous amount of psychological component to the experience of back pain.
Yes. I remember there was a doctor in New York City years ago.
Sarno?
Maybe it was. I know Howard Stern went to him. Howard Stern had this back pain. He was a shock jock. He's still on Sirius. And he went on and on for weeks talking about how this doctor said it's all in your head.
That's him.
And he didn't. Yeah, sorry. And he didn't believe him, and then he got his mind around it, and then his back pain got better. So let's just say there's a component of in your head that contributes at least to some back pain.
There is a component in your head to everything that comes into the emergency department, because what is our experience? What is our perception? You know, back pain is an experience. I am feeling something. It's a feeling. Let's get all touchy-feely about it. Back pain is a feeling. Is it a physical thing? Sometimes it is. You know, if you have a tumor in your spine.
Yeah.
But many times it's a perception. It's a feeling. It comes with maybe some muscle spasm, maybe some torquing or misalignment. But it comes down to a perception of discomfort. It is a feeling we're having. Why is it that you can trip and twist your ankle and you're busy and distracted and it hurts a little bit, but then it goes away? Or other times you're stressed out, you're walking slowly, you're worried about many things, and you do the same movement with the same twist and it becomes unbearable and you can't walk. What was the difference? It was your mindset. There is a big component of perception and how our mind regulates that perception to our experience of pain. And back pain is the prime example. Is there a magic recipe? Absolutely not. I have been on the floor, unable to move with a back spasm. Miserable. And I'm thinking, well, I know I didn't break my back. I know I don't have a herniated disc, but I can't move. I'm also maybe sleep deprived and stressed. And I'm gonna have to take some pain medicine and a muscle relaxer so I can start moving again. That it happens, but I also know probably a good component of that was emotional. So every time we see someone with back pain, how much of this is an infection in the spine, a tumor in the spine, a herniated disc putting pressure on the nerves, and how much of it is not? And you're going to be okay, because the vast majority of the people get better with time. And we just want to help them through the hump. Here's some medicine. Take it. It'll help you through the hump. You're going to be okay, but you have to give it time. And people have to go to work. They don't like that. They need to go back to their job and move around and take care of their kids. Unfortunately, we do not have a quick and easy solution for that. And it becomes incredibly disheartening for us, because we just want to go in and help people. I didn't go into this to make money. I didn't go into this because it was easy. I went into this because it's very, very satisfying on a selfish level. It's very satisfying to help people. Like, wow, I was able to help them. And it's lovely.
Make a difference.
People with back pain, especially chronic back pain, it's very disheartening for us because we really want to help them, but we can't make it go away. We can just help a little bit without giving them medications that will turn them into
a drug addict.
Give them another illness, another dependency. We want to help, but we also don't want to put you in a situation where you become dependent on a medicine, be it just a muscle relaxer or an opiate.
Gotcha. Well, I am learning so much from you, Orlando, and we could go on forever, but I'm going to start tapering this down here and prepare to end this. And I want to talk to you about a couple more things that people always want to talk about or are interested in hearing about. I went to an emergency department down in Arkansas. It was in Mountain Home. It's between Norfolk Lake, Bull Shoals Lake, and the White River. You know what the people do there? They fish. They fish. And I don't know if it's still there. I probably is. With these two, however many, display cases of all the fishing hooks and lures they had taken out of people's bodies. How do you take a fish hook out of somebody with a barb?
I think a lot of people know this, right? You have to push it all the way through. It's the opposite. Instead of pulling it out, because you can't, you push it all the way through, and then you snip the barb off, and then you can pull it out.
And if it's a deep penetrating, you give them a tetanus shot or make sure they're up to date on tetanus.
And sometimes we have to numb up the finger or numb up the area because otherwise it's too uncomfortable. But there's a lot of fishermen never come in. A lot of fishermen know this, and they just push it through.
They just drink some more whiskey and then take their pliers and they already have.
And they do it to their kids, so the kids are just like, okay.
This is gonna hurt, Johnny. So that's the display down at the Hospital Mountain Home. Now, apparently, and I don't know this one, apparently there's a display, maybe it's in the back at I think the new NYU Emergency Department in New York City, I think, of all the objects they've taken out of people's bodies, more of the rectal or genital
I didn't know
area.
NYU had something like that.
I heard. I could be totally wrong. Okay, I just know I was heard that there's a collection of objects that have been taken out of people. That,
we take things out of every possible orifice.
Every orifice.
Every single orifice. Yes.
Now, I remember when I was a medical student, there was a gentleman showed up, and he had a metal hose in his hand, and it ran down into his pants, and connected to it was a shower head that was in his rectum. And he came in, and everybody, talking about the triage people, everybody's trying to keep a straight face, on about this issue. So, what do you do about foreign objects, and how do you keep a straight face when you're dealing with somebody who's obviously embarrassed and in distress?
Yeah, people who come in like that usually won't give us the straight story initially, and we have to
they fell on
ask a lot of questions. Yeah. I think the providers in general, the docs and the PAs, nurse practitioners, we usually don't even have to keep a straight face. For us, it's just, what's the problem? Let's just take care of it. It's more everybody else around who starts snickering and laughing. For us,
the fresh medical student or something.
What's the problem? Just tell me. Let's just take care of it. Move on. So, bugs in the ears, common. People who are sleeping outside, or people who are sleeping in an environment with a lot of insects. At night, the insects are looking for a place to hide, and cockroaches and flies and other things stuck inside the ear canal. We do see that regularly. Kids love to stick things in their noses. So we see a lot of things in noses.
Peanuts, marbles,
anything that'll fit.
Anything that'll fit.
Most people who put something in their rectum usually are able to take it out. So it's not as common. And then there are more challenging things in people who have either more, let's say, extreme or out of the ordinary habits, or more people who have mental illness.
Yeah, psychiatric disease.
That will put foreign bodies in even smaller orifices.
Yeah.
And that becomes very challenging.
So that's where you need to have a general surgery on hand.
Sometimes people have to go to the operating room
and take it out from above.
Or from
somehow.
Depends on where it is. Yes.
And sometimes it's glass, and if that were to fracture, it would be a horrible laceration.
Yeah. Some things cause a suction in a vacuum, and then they can't
Yes. I know there's techniques to break suction.
When I was a medical student, I saw a guy who would eat a big bag of sunflower seeds every day. But he wouldn't take out the seeds. He ate the seed with the hull.
The whole seed.
The whole seed with the whole hull. And he would just eat them by the handful every day. And of course, his body did not digest the hulls, only digested the seed. So all of the hulls formed a spiky rock.
Called a bezoar, right?
A bezoar in the stomach.
Okay.
But his was in his rectum.
Oh, my goodness.
And it was just there. It was fascinating because he was like, I don't know why I have this. I'm like, well, dude, you're supposed to just eat the seed. Don't eat the hulls.
And it wasn't eliminating. It was just building up.
It was just building up because they would get stuck.
Concreting.
Yes. And it turned into a large, spiky mass because it was all the shards of the...
Oh.
Yeah. So I remember it cut through my glove.
It cut through your glove. What's this sharp thing? Oh, my goodness.
Yeah. And I remember I was like, why is this sharp? And then I look over, and on the counter next to his bag was a bag of sunflower seeds.
Clue. Sherlock figured it out. Watson, we have a diagnosis.
I think he had to go to the operating room, yeah.
Oh, my goodness. Orlando, that's a great story. That's a new one. I've never heard that before.
So is it a bezoar when it's not in the stomach? I don't remember.
I don't remember either. I just remember I remember when I was a medical student, this little old lady had a bezoar in her stomach, and they had to go in and take it out.
People who eat styrofoam, it you know how when you burn styrofoam, it just kind of shrinks into this hard plastic?
Yeah.
So people who eat styrofoam will get a bezoar of this hard plastic in their stomach.
Amazing.
So don't eat that styrofoam. Don't eat the plate when you're eating the tacos. Okay.
Fantastic. Well, with that piece of advice, Orlando, I want to thank you for a very stimulating conversation. I have learned so much.
Thank you.
What a pleasure it is to have you here. What a pleasure it is to have you as a friend and a colleague here, and know that I can always depend on you when we go to the emergency department.
And thank you for your time, and I hope everybody does well.
Thank you, my friend.
Yeah.